So I was thinking, how should I begin today's presentation? I'm delighted to be here and to talk to you and initiate a conversation about this pretty, I would say, provocative set of topics. And then I looked at the cookies at the table. No, I have to be honest with you. Maybe after today, you will think about it. So what I'm trying to say is there are plenty of gluten-free varieties, right? There are like 2 or 3 of them. But there's nothing sugar-free. So we're very conscious about the gluten in our diets, but we don't think necessarily as much about the sugar. And so that would be my kind of a foray into the conversation. So why the 3 Ds? Just to briefly give you a history. About 10 years ago, I was asked to edit a book on insulin resistance. And when I was writing a preface on that, I was thinking, so what are the main illnesses where that condition is prevalent? And it just came to me. It was depression, which we study in my lab for the last 20 years. It is dementia, which we also know quite a lot, and it's one of the pivotal studies done in the neuroscience of dementia. In fact, you may have heard that dementia is now being coined as a type 3 diabetes. And in diabetes, obviously, because insulin resistance is one of the conditions preceding development of type 2 diabetes. So that's how the term of 3 Ds came about. Now, I will start with bad news, and then as we go along, I will try to end up on a more positive note. So you know how they say we have good news, we have bad news. So I'll start with bad news, and then I will try to make a case how it doesn't have to be that. So a little bit of numbers. I try not to slow down with numbers, but those are the costs associated. I don't need to read it to you, but you could see it. There are the costs associated with each morbidity. One thing I will point out, however, and that is that depression has become, and actually next year is the year which we were waiting for a very long time, not because of the elections, but because unfortunately in 2020, by the WHO projections, depression will become #1 morbidity in the world. #1. It's very scary. It will surpass the cardiovascular disease. We don't know yet if those predictions will come true, but clearly the number of people in all kinds of countries, by the way, independent of the socioeconomic status or the way of development of the country, the prevalence of depression grows very, very rapidly. So this is going to be one of the significant dilemmas to deal with as time goes on. We certainly know about dementia. Dementia is a horrific problem as we all, as societies age, we all encounter. And dementia, unfortunately, has the highest, at this time, per year cost associated with that. And diabetes, of course, is an epidemic, and that is something I would probably try not to talk too much about just because it's a huge topic in itself. So looking at the known kind of connection to diabetes and to depression and actually now to dementia is obesity, right? And that could be 3DO if I were to be that inventive at that time, but scientifically speaking, actually, obesity is not always associated with insulin resistance. So I'm still okay there. But if you look at the distribution, according to the geographic prevalence in the United States alone, you could see how consistent the patterns are and how they grow in the same direction with each time assessment for both obesity and diabetes. Now, at this point, we believe that about 20% of adults, and we don't know how many kids, in the United States have insulin resistance. And the number could be underreported, so it could be many more. So what is insulin resistance, and why do we care about it? First, I'll tell you just a little bit about the insulin itself. So I'm sure everyone in the room knows that insulin is a hormone produced in the pancreas in response to food. So there is a pulsatile production of insulin with a certain changes through the 24-hour cycle. But with the most purpose of in the periphery of the insulin is to help food to be processed, and specifically the glucose as a component of food to be utilized. What happens in the condition of insulin resistance, I could compare it to the clogged sink. So if you all of you, I'm sure, saw the clogged sinks, when they are not fully clogged, but partially occluded, and the water from the faucet is dripping, if it's even a very small, weak stream, drips, if there is a clogged bottom, eventually the amount of water will stay up, right? It doesn't necessarily have to spill over, but it will start accumulating in the sink. That's the condition of insulin resistance in a nutshell. What it means is that the insulin receptors become immune, not accepting any more insulin. And therefore, there is more ineffective insulin floating. And it takes years, and actually in some cases probably decades, for the other illness to develop. So take-home message from that is that the insulin resistance may happen insidiously without being diagnosed for a very long time until it would become or diabetes or become a risk factor for cardiovascular disease or for dementia or for depression. So it doesn't necessarily have to go just into diabetes. So said that, there is a whole host of other properties insulin has in the brain. And so this kind of a technical slide pertains to the effects, bless you, pertains to the effects of insulin in the central nervous system. And that is not always and not fully related to glucose. And in some cases, it's not related to glucose at all. So what does it do? In the brain, it's a very potent, very effective neurotrophic factor. So it's responsible for the plasticity of the neurons, their ability to connect with other neurons, their ability to survive adverse conditions such as hypoxia or the altered blood flow as a result of the, for example, a blood clot, etc. It also has significant interaction with various neurochemicals which are responsible for regulation of mood, for memory formation, for memory retrieval, and for the specifically the inflammation in the brain. So there's something we call neuroinflammation, which doesn't necessarily exactly accurately describes what we mean, because it could be a neural, right, peripheral neural inflammation, but this pertains only to the central nervous system. So insulin is a very powerful player in the brain, and it has very little to do with the glucose in the brain. So the condition of insulin resistance is actually truly ubiquitous from the standpoint of all kind of various problems it may be associated with. And those are going to the vascular changes, blood changes, big illnesses, specifically with a tribute to Stanford's own Dr. Gerald Reven, who I'm sure you heard of, who recently passed away, who was a father of Syndrome X, which has become, after that, probably one of the most prevalent syndromes we have. It's a metabolic syndrome, or Syndrome X, which he coined at that time, but now it's called insulin resistance syndrome. It causes major somatic problems such as atherosclerosis, changes in the vasculature, in the heart, in the microvessels, in the vessels in the central nervous system. As I talked before, diabetes, hypertension, etc. Now, one thing to keep in mind, and I think I really try to give you a dim sum, right, of our data, because I don't want to go too much into detail. But I think it's worth of mentioning another kind of a take-home note. And that is that insulin resistance may or may not be a consequence of weight gain. So I don't want you to think that if in your life you go through certain periods of weight gain, that's imminently will be associated with increased insulin resistance. There are actually plenty of very thin people who are very insulin resistant. So that's the kind of again, another level of complexity in that. Now, let's shift gears a little bit. So there's this condition which means that there's a lot of ineffective insulin floating around. Whatever passes the blood-brain barrier, right, and goes to the brain is not enough. And so there could be all kinds of things in the brain, and I'll show you a little bit of what we see in people who have insulin resistance. But why is it important in general? One of the more ubiquitous terms we ever have is stress, right? We're all stressed out every day, every minute, one way or the other, more or less stress. Now, there is a very elegant conceptual framework of the biology of stress and the way stress develops, maintained, and affects various organs in the systems. So this one, oops, I moved too fast. This one pertains only to the various contributions to the stress as it affects the central nervous system. So we, of course, know that major life events, they could be positive or negative. They clearly affect stress levels, the trauma. And that is something, actually, I just parenthetically will tell you. As a person who started my research in aging, I'm doing research in aging for the last 30 years. We're moving now with an understanding of what causes pathological aging to early childhood, to adversity in early childhood. And that is the bad news. That's truly the bad news. The good part of it, the silver lining, is that as we understand more about the role of trauma, we can try to avert it and precede the development of pathological brain changes. The environmental stressors, the pollution, not biking to work, or in the opposite, biking on a freeway when you have all the cars passing you by at 80 miles an hour. So there are all kinds of stressors there. There is certainly genetic predisposition to certain stress vulnerability, or, if you will, resilience in the opposite. So there are people who respond to the same stressor with catastrophic reaction and some with very little reaction. And then there are behavioral responses, right? So the behavioral responses are, which we know all too well, fight or flight. It's not only one. but it's also the lifestyle changes. For example, there are many people in this room, if I were to poll you, I'm not going to do it, if I were to say, if you're very stressed out, how's your appetite? Do you eat more or less? There will be a lot of people who will say they eat more. There are, however, a group of people who eat much less, and they can't even consume a certain amount of calories per day. Drinking alcohol, using smoking and exercising or not exercising, so there are all kinds of behavioral responses to stress. Now, why is it important? We all know that. It's all old news. However, all of this pertains to the notion of allostasis. Allostasis, and this is the last glossary kind of item for today. Allostasis is what happens in the body and in the brain as person moves from one stage of his or her life to the next and experiences various stressors. So the allostasis is the cargo, our own cargo of life. And if this cargo is well appropriated and people have enough ways to work through that, there is an adaptation, which is a good thing. If there is no strong system of reduction of stress, whether it's a behavioral reduction, whether it's changing of environment, etc., what happens is there becomes an accumulation of changes in plasticity of the brain, in the cardiovascular system, in the immune system, therefore with higher risk for various cancers, etc., which is called allostatic load. So the allostatic load is what we all have, and if we can recognize stressors and appropriately deal with those stressors, this will be not very burdensome. If not, then unfortunately we are at high risk for developing major illnesses and premature brain aging. So very, very quickly, I'm not going to dwell because it's basically just taking the same concept I showed you in the previous slide, few thousand feet down. So these are various hormones and inflammatory biomarkers which work in concert. Actually, I have to tell you, one of the early experiences in my life when I was a medical student, one of my professors said, you know, brain is actually a very small organ. And I was not necessarily agreeing with him because I thought the complexity of the brain is so powerful and elusive, especially at that time. But then I recognized what he really tried to say, and that is a concept I invite you to think about too. Everything, you know, this old British song, everything goes from one bone to the next. This is the brain. Everything is connected. One system is inevitably affecting the other system, and the other goes to the third, and the third logs back to the first, etc. So in a very primitive kind of a caricature way, I can say that everything in the brain has its own interactions. And our task is to understand not only the really in-depth connection of one system to the next, but also to take a step back and to see where we can affect the pathological cycles when they occur. So one of the pathological cycles, and the only one for today. So what happens in the brain, which is occurring in depression, depressive disorder, in diabetes, and in Alzheimer's disease? Insulin resistance leads to inadequate glucose utilization. Those two events happen in the periphery, and then is associated with changes in the metabolism in the critical areas in the brain. What does it mean, changes in metabolism? I will illustrate. Let me go right here. So this is the worst part of news, and then after that, hopefully it will start getting better. So this is the data from one of the now associate professors at Stanford in our department, Manpreet Singh. And it's her study. She is a associate professor in the child division, and she is responsible for all the research in mood disorders in children and adolescents. And Manpreet has a study looking at the insulin resistance in depressed adolescents not treated. So why is it such a bad news? Because we unfortunately see the changes in the brain in children and early adolescents in relation to their insulin resistance in the periphery. So we can detect it now very early. That's not good. And it's good that we detect it. It's not good that they have it, right? So that's the worst part of news. And that's how the connection in the brain looks like. If it's not present, it's in the red. And if it would be, and you can see there's a very nice direct correlation between the degree, the extent of insulin resistance in the peripheral blood and the brain connectivity. I'll go back to the hippocampus. So how many of you heard about hippocampus? Everyone. Okay, good. I don't need to talk about that then. So hippocampus is truly a fascinating part of the brain in a number of ways, not only because of its own function in memory, in various emotional regulation, in its connectivity, and specifically in its connection to the prefrontal cortex where we make all the decisions, right? So the so-called executive function, it's on the prefrontal cortex, so very strong projections. But more fascinating, hippocampus has the highest clustering of insulin receptors and cortisol receptors. And they are what we call colocalized. So they travel together. And if there is stress and more cortisol, as we all know, cortisol, so-called cortisol toxicity in the stress and depression, in diabetes and dementia, there is increase in insulin as well. So those two conditions are tightly connected in the brain. And that's why it's so important to understand what insulin can do in the brain in a positive way, but also how to decrease when it's pathologically ineffective. So these are the main illnesses you probably heard in which the volume of this part of the brain decreases. What we know about that is twofold, threefold. It's decreased in depression, in PTSD, in post-traumatic stress disorder, in type 2 diabetes, etc. It will be irreversibly decreased in Alzheimer's dementia. And finally, the good news, first good news of today, it actually can regenerate. And this is one of the most interesting parts of the brain, that it can regenerate with a certain non-pharmacological, some pharmacological, but non-pharmacological interventions, and I will show that. And none of them are new, but the science behind this is fascinating and very kind of hopeful. So, my lab, just to tell you a little bit, I don't work in dementia per se research. We do very little. We work with people who are at risk for dementia, because one of the ways I'm interested in affecting the brain is trying to predict who is going to develop it and hopefully postpone that development, or maybe in some miraculous way protect the brain from developing dementia. So the data I will show you in the next few slides is all about people at risk. All of them are cognitively normal according to their age-related cognitive performance. None of them have dementia. The risk of dementia here in all these studies is denoted as the genetic risk by having one at least first-degree relative with dementia diagnosis or having the genetic risk factor such as ApoE4. I'm sure you all heard of that too. So this is the older study we done in early 2000s. We looked at women at genetic risk for Alzheimer's disease, and we looked at their hippocampal volumes in relation to insulin resistance. And what we found, again, very similar like with children you saw, if there is more insulin resistance, the hippocampus is smaller. This is just that simple. This is the data from a person by name Suzanne Kraft. This is her lab. The first author is Laura Baker, but this is Suzanne's lab. Just to show you, this is the in vivo brain metabolism done by the positron emission tomography. Again, I'm sure you all heard of it, PET. This is the FDG, the fluorodeoxyglucose. So it's a radioactive glucose which gets injected in the vein and then taken up by the brain. So it shows how the neurons function in vivo. We watched that. So you could see that there is, and this is the area which is also very strongly implicated in the early cognitive decline in one of the main, more vulnerable areas in dementia. So people who have just insulin resistance, not diabetes, not dementia, cognitively normal, have changes in the brain exactly the same as if they were to have dementia. So we have this accumulative body of evidence to suggest that being insulin resistant is really not good for the brain. And we're talking only now about the brain. We showed the same thing in another area which is projected to the hippocampus. This is prefrontal cortex. As I was telling you, this is the executive function. Same thing again, more insulin resistance, lower metabolism. It means that the neurons in that area of the brain do not function to full capacity. That's all it truly means. Now, so how does that all relate to stress? Well, as I said before, one of the most kind of unusual, unexpected discoveries was to look at the childhood trauma. It came, by the way, completely serendipitously in our work, because the neuropsychologist who was testing those subjects in the study said, Natalie, you know, all of these women have been or abused emotionally or abused sexually. There's a lot of trauma which they endorse in questioning. So we started systematically evaluating it, and we found that there are a number of specific types of abuse which are more predictive of the brain changes in midlife. And one of them is actually the emotional abuse. The emotional abuse is something we will probably had if a parent is screaming, or a sibling, there's a lot of fight, or peer pressure. It's all kind of emotional, sustained emotional intervention. And if it's really becoming impossible for the person to tolerate, unfortunately, they are prone to have pretty significant changes in the brain plasticity and then decreased hippocampal volume and insulin resistance. In fact, I will tell you something else which you, I'm sure, heard. A lot of people who have been abused, not necessarily women, only men as well, they tend to try to find comfort in food. How many of you heard that before? Yeah. So basically, there has to be somewhere the outlet. Of course, some people go to drugs and alcohol and maybe other risky behaviors, but a lot of people go, it's, in fact, tons of movies done, right, with ice creams, right, with all these gallons of ice creams people consume when they're stressed out. So in a way, it actually ties to the notion of insulin resistance because, and then back to the cookies, which are gluten-free but not sugar-free. Because if there is too much glucose and there is not enough insulin, it facilitates that inability to utilize the glucose. And what happens with that? Excessive glucose initially becomes fat as one of the pathways, metabolic pathways. So people do gain weight when they eat too much ice cream. They don't gain as much weight if they would eat some fat, for example. So the carbohydrate, pure carbohydrate, is more damaging. And second, it would lead to the changes in the brain related to the appetite because the glucose ensues more appetite. So you eat and you want to eat more. One of the reasons, by the way, behind the notion that Diet Coke, which doesn't have glucose, is very bad for you because of the sweet taste. The sweet taste activates the regions in the brain which create the desire to do more and to eat more. So that's, as I said, everything is connected one way or the other. Now, let me start wrapping up by the good news. So what are the good news with all that stuff so far? Can't eat, stressed out, what's good? Here is the funny thing. There are simple things which actually have been now shown in number of studies, both in animals and in humans, that the regular aerobic exercise is associated with regeneration, what we call neurogenesis in the hippocampus. What it means that hippocampus can increase in size. So if it's been decreased prior to exercise, consistent, appropriately dosed aerobic exercise is associated with the improvement in the hippocampal volume. So that is in itself incredibly exciting discovery because we can actually try to return it back to the premorbid condition. Even if it's not fully restored in the size, the most interesting part right now for the research in neurogenesis is to understand what these new neurons will do, how they will affect the mood, the cognition, the memory, etc. Similarly, with intense learning, for all of you who don't know the second or third language or fourth language, please go and study it because it does make hippocampus larger. And finally, something quite controversial because the antidepressants have all kind of mythology about them. But in fact, specifically serotonergic agents like Prozac and the company and whatever ensued after that are clearly associated with increase in hippocampal volumes, especially in those who have major depressive illness. So that is something to keep in mind when we think about the kind of the well-being of the hippocampus and therefore the well-being of our memory. So this is the study. I just wanted to show you one study on the exercise training, how it truly is increasing both. You can see that both sides of hippocampus after a year keep going up in the volume. I just thought it would be something to kind of entice all of you to exercise. And again, I'm sure most of you exercise one way or the other. Aerobic exercise is the way. It doesn't have to be jogging, running, or anything of that sort. By the way, there was an article in the Times, I believe, 2 days ago or something, No, it was in Stanford alumni magazine, if you saw it. Dancing is the best exercise for aging memory. Seriously, this is the most incredible finding. And now, actually, our neuroscience health center, which is on Quarry, has classes for elderly, especially for patients with the Parkinson's disease, to, in a certain observational way, of course, with the guidance of the dance therapist, to improve the movements, and it improves the hippocampal function as well. All right, so I will finish on this, and we'll do the Raffle and then the questions. So this is the trajectory of the good and bad, right? Going from the pregnancy and early child experiences, if they are not good, right? If there is a condition of insulin resistance, which I did not talk about today because it would be way too much. But this is something babies are exposed quite often in utero, which is the gestational diabetes, pregnancy-related diabetes. If they are exposed to early trauma, if they have all kind of stressors, poverty, right, abuse, etc., they have a different trajectory of developing those bad illnesses we're discussing today. And insulin resistance, it actually emerges before these bad illnesses may ensue. So if we can deal with insulin resistance with exercise and diet without even medication, but by doing that, we can protect the brain, among other organs, but today we talk only about brain, protect it from all kind of inflammatory and atrophic conditions. So this is what I consider good news, that although this is an insidious inflammatory state which can lead to a number of negative outcomes, it could be recognized early, it could be amended fairly well with the appropriate intervention, and it can protect, I would postulate, from largest morbidities we're dealing with in this century, which is the depression, the diabetes, and the dementia. I'll stop there and I'll let you guys have the Raffle.
Thank you very much, Dr. Rasgon. Need a drum roll. Okay, the winner of our raffle is 838-2928. That's 838-2928.
Congratulations. Excellent.
Want to hold it up?
Any questions? Go ahead.
Hold on one second.
I have heard an observation that depression may be more prevalent with people who are more affluent because they don't have to put so much effort into meeting their basic needs, so they have time to worry about being unhappy. Any observations on that?
Could you repeat the questions? I really didn't understand what you said.
Okay. People who are more affluent,
Yes.
who are better off,
Right.
have more time to worry about being unhappy and therefore are more likely to be depressed.
Yeah, so the question of the affluence or the socioeconomic status, I would call it this way, with the level of depression. It's a complex issue, actually, and I'll tell you something. I try to stop me when I start answering because I can go on for a very long time. We did a study, actually, at Stanford 2 years ago. We looked at the executives, and one thing I didn't bring here today, so maybe sometimes you'll invite me again to come back, is the telomere research. And you all, of course, know about telomeres, and we did a lot of work with telomeres. So actually, just to tell you, telomeres are shortened in insulin-resistant patients, so just to give away that part. But we thought that executives will have shorter telomeres as a result of more stress, right? Because if these people run company, I would imagine they're more affluent because they run companies, they would have shortened lifespan as a result of increased stress. Actually, the finding was opposite. One of the times when it's so fascinating to get a negative finding, because they actually did great. Their telomeres were fine, which means that they are actually or more adapted to stress, or they're more resilient. So the notion of resilience could come in, and that could be also because they're, not because necessarily they're richer, but because they have experience adapting to various situations to a larger extent. Yeah, go ahead.
You mentioned hippocampus volume as an indicator of recovery. Was there a correlation between the volume of the hippocampus and the actual memory function? Was that studied?
That's a great question. In animals, yes. There was improved memory function in animal studies. So one of the most important parts of the hippocampal function is learning. Mm-hmm. And in specific modeling of the hippocampal dysfunction in animals, when the animals were exercised aerobically, their performance in those behavioral models significantly improved. So it was associated with humans. Humans are very messy animals, just to tell you guys. I mean, it's just one of those things. There's so many other things which can play into that. But in animal models, it's a clear improvement in behavior. Yeah, go ahead.
I wanted to say something about the executives. They may have a lot of stress, but they get to decide what they want. They don't have anybody deciding for them. But I have another question. How intense does the exercise need to be, and how intense does the learning? You said intense education.
Intense learning is a little different from intense exercise. So I actually, and again, it's my view. Please don't extrapolate it to anything else, like NPR. It's only my view. I believe that intense exercise, a real, very strenuous exercise, is not healthy for a majority of people. What I'm discussing is the consistent moderate aerobic exercise. For example, walking, but sustained, not necessarily a power walking and going into these interval trainings. That's not necessary. Just sustained walking would produce enough exercise. If you're talking about learning, however, it's very different. So, for example, learning a new movement involves significant amount of not just the peripheral musculature, but also the brain regulatory phenomena, not just in the hippocampus, the executive function, the motor function, etc. Intense learning of the new skill is very important, but then it couldn't be that, if, for example, I want to learn Chinese, if I study, 2 letters today and then 2 letters in a week, I clearly will not do well. So it has to be a fairly focused, sustained attempt at learning. Yeah, go ahead.
Have you been exposed at all to the method of fasting or intermittent fasting?
Yes.
To bring the blood sugar down, reduce insulin resistance, and let the body heal itself?
Great question. Thank you for asking. Yes. So, a whole other topic too, but this goes a little more towards obesity rather than insulin resistance and diabetes, and I will explain why. One of the myths is what food we eat is important. I postulate how much of the food we eat is much more important. It's a simple mathematics, right? What goes in has to be less than what comes out, right? Then person loses weight. It's just that simple. So if I go to exercise, say in the gym, and I stay on the treadmill at 3 miles an hour for 20 minutes, and then I go eat a hamburger, believe me, I don't need to go to the gym. It's worthless. I didn't lose anything. Caloric deprivation, however, has a very strong effect on the energetic balance. So in a way, it's almost like you have this, crocodiles and you do the jump start of your engine. That's what happens because the metabolism shifts from one metabolic pathway to a completely different one. Intermittent fasting is not associated with the ketone body production as much as longer fasting. But you heard, all of you, I'm sure, heard enough about ketogenic diet. That's the purpose of it. So it's basically deprivation from the carbohydrates to mobilize the ketone bodies, which will shift the metabolism and then therefore jumpstart the function. The reason it's good for the appetite control and for the longevity and all that is based, again, on the metabolic reshuffling. But from the standpoint of insulin, however, it's much more dangerous, and I will explain. Again, insulin is oscillated, it's produced in an oscillating fashion from the pancreatic gland. If a person has some dysfunction there already, and they do not get any food in for sustained, in the fasting, right, there's no food, just drinking water. That creates a certain accumulation of insulin. So when the person finally eats, there is this exaggerated release of insulin. And that actually also relates to the appetite because a whole other chemical in the brain gets produced more and dopamine. And then people want to eat more and they have difficulty stopping to eat. So from the standpoint of insulin resistance, it's not a very good method. But people do use it. I would say caloric deprivation, if it's done appropriately with a certain purpose and well monitored, is a good method to change the metabolic rate in the body.
How about the keto diet? Is that good?
Keto diet, it's a very difficult diet to really truly adhere to. And like any diet, so now I will put on my shrink's hat on, right? So if you think of any diet, no diet nobody is able to be on a diet forever. By definition, it's a deprivation. It's a certain constriction of your will. And by itself, it causes a psychological reaction to or cheat, or stop, or rebound when you stop it. I mean, say you lose 10 pounds on a ketogenic diet and then you eat one candy and forget it, it's all going back. No, not from the standpoint of weight, but the production of ketones gets interrupted. So then people need to achieve again at a very harsh food intake, very limited food intake, achieve the ketosis. Ketosis is not easy to achieve. Yeah, go ahead.
I'd like to explore this intense learning a little more.
Sure.
Did you say that it's not only the intensity of the learning, but the frequency of the learning?
You're right. I did not specify it. I don't think there's enough data for that. But I will call anything infrequent, less intense. Because if you think of any learning process, like any other type of exercise, it's a mental exercise. If it's done in this, again, in a systematic way, with a certain duration, that will be potentially, hopefully, producing certain changes in plasticity, neuronal function, etc. If it's just sporadic, exposure to some new information, it will not be as effective. But studies are needed to do that.
I mean, so you do crosswords 8 hours a day and have something?
Yeah. So the crossword is very good. It's not necessarily new learning. It's much more of the memory training, right? Because basically you're just retrieving information from your brain. You're not necessarily learning something new. But literally going to the language, new language acquisition, even in a smaller, kind of more superficial level, maybe not writing and reading, but trying to speak another language or listening to another language, radio or television or a movie, that is more intense learning. Yeah. Any more? Yeah, go ahead.
What about learning music?
Sorry, I apologize, I didn't see you.
Oh.
Yeah.
What about playing music? And
Music.
learning a new piece of music?
Absolutely. Music and music therapy, it's an incredible tool to improve the brain function. Absolutely. Absolutely. Yeah, go ahead.
I just have one question about your slide. So a woman who has insulin-dependent gestational diabetes,
Yeah.
what is the correlation that she'll develop depression and dementia and... I mean, to me, the insulin-dependent diabetes thing was pretty new. I wasn't too familiar with that.
Okay, first of all, it doesn't have to be insulin-dependent. So okay, as long as I put it on a slide, I might as well answer.
Thank you.
Gestational diabetes is a condition of the impaired glucose control only related to pregnancy, as we used to think for decades. It's not true anymore. Now we have opulent data, evolving, emerging mountain of data to suggest that women who have had gestational diabetes, it doesn't have to be, again, insulin dependent. It could be, usually it's regulated by the diet or non-insulin if they can avoid insulin. It carries a significant risk for a woman and for the neonate to have more cardiovascular disease later. It's a risk. It's not a surefire causality, but the risk of associating the gestational diabetes with, say, later, years from the pregnancy removed, type 2 diabetes has been shown. Cardiovascular disease has been shown in women. Children have certain changes in growth trajectories, right? So being exposed to the inflammatory condition of diabetes is not good, even if it's limited just to the 9 months of pregnancy. And usually it's not even that, because gestational diabetes occurs somewhere at the end of the first trimester. So it's not full 9 months. Yeah, one more?
So, how do you know if you have insulin resistance, and how can you prevent insulin resistance? And if you have it, does it go away later?
That's a very good question. How do you know that you have insulin resistance? There is a very simple test, blood test, which can be done anywhere. And it's a fasting plasma insulin and fasting plasma glucose taken in the morning. Again, because of the oscillations in the production of the insulin. And there is a certain ratio which the doctor can interpret and say if you have a need for additional tests, etc. So that's the easiest thing. The other way is, as you all heard, and I know you did, is the metabolic syndrome, which is a constellation of 5 different types of pathology. One of them is waist circumference. Waist circumference has a certain age and gender specific numbers. If it exceeds that number, a person has 80% chance to be insulin resistant. How to prevent it? I don't know how to prevent it except to say that that would be the major coup for a lot of various illnesses. How to treat it is change in diet and exercise, and sometimes very simple insulin sensitizing agents. So the recent vogue we're living through of metformin is one of the ways to decrease insulin resistance. Pioglitazone, liraglutide, all these insulin sensitizing agents, a lot of them doing a great job of reducing and reversing insulin resistance. The trick there is, and I don't want to go too much in that because the time, and also because it's not very good news. It depends where in the cycle of evolution of insulin resistance the person is identified, because some stages, early stages, are much easier to be treated and dealt with than later stages. So, but the trick is not to get to diabetes, not to get to cardiovascular disease, and to hopefully protect from the pathological brain aging. Thank you, you're a great audience.